Hi, for those I haven't met, I'm Shannon, and I'm going to be talking a bit about pre-hospital antibiotic administration. So I'll get a bit of a consensus from those in the room to begin with. Sort of keen to hear the practice of what other people do. Who, at the beginning of their shift, grabs cefazolin and puts it in their drug pouch? Anyone? No? No? Do you tend to, just if you need it, you'll go to within the drug bags? Yeah. Yeah.
In the pouch, I don't take it out, but I don't put it in.
Yeah. Okay, cool. That's a good one. And I think, I wonder, I notice, variation in practice, and I'm always keen to see what other people do and what they take out and what they prioritise at the beginning of each shift. And I'm wondering whether it's sort of, more that we've been brainwashed by the orthopaedic surgeons in always giving 2 grams of cefazolin before anything. But I do notice a lot of cefazolin floating around in the pouches for each shift. So we'll sort of, for the purpose of this discussion, we'll be talking about pre-hospital antibiotics in the setting of trauma. There is a lot of evidence and discussion out there about early administration of antibiotics pre-hospitally for patients with sepsis and reducing that time to antibiotic administration in patients that the paramedics are identifying as being septic, which I think is a really good idea. I'm reducing that administration time, but there hasn't been shown to be any proven mortality benefit of that as yet. So I think that that's sort of still a work in progress. But I guess if we think about the jobs that we get tasked to and the common scenarios that we're seeing, it's not really the septic patient at home, but rather our trauma patients with, open fractures and things like that. So that's what we'll keep the discussion to today. Hey, Mel. So fortunately, there is a lot of good literature reviews in regards to the use of pre-hospital antibiotics and a lot of recent discussion. The topic remains controversial, but mainly there is now a lot of good discussion about choosing the right patient, the right injury, and the right antibiotic, rather than just a blanket administration of antibiotics for all trauma patients. I think that we've all seen, as we roll into an ED and drop off a patient and that person with superficial abrasions and they get 2 grams of cefazolin and an ADT regardless, no matter what they have to say or how deep the abrasions are or what the mechanism was or where the injuries are. So there certainly is a push in the literature to move away from that, but rather be thinking about each person on an individual basis and the most appropriate antibiotic for that type of injury. So when you think about the need for antibiotics, there's a lot of different factors that contribute to that in what, is leading the host to develop infection. It's not just simply the dirty environment that the trauma is occurring in. And, we do know most traumas occur on roads and things like that where there are a lot of pathogens, but also the impact and the physical force that traumas cause and the tissue destruction that results in, as well as then their ongoing course as they developing multi-system organ failure and sepsis and reducing their response to or their immune responses. So getting in antibiotics early is beneficial in some of these patients, not just because of the type of wound. So thinking about multiple factors for the patient. So firstly, we'll look at, we'll go through this in sort of an injury type pattern because that's where the sort of benefit of antibiotics is shown. So the initial thought for head trauma is that patients with traumatic brain injury, such as base of skull fractures, are at a higher risk of developing meningitis because of the potential bacterial contact between the sinuses, nasopharynx or middle ear. And that anyone, with a CSF leak was at particularly higher risk, and hence all of these patients should have antibiotics. However, it has been concluded that with the current available evidence that it doesn't support prophylactic use of antibiotics in these patients, regardless of whether there is a CSF leak or a base of skull fracture, and that there isn't a correlation between the injury pattern and the development of meningitis, which I thought was interesting. And because the rates of infection themselves are so low, prophylactic antibiotics aren't required in these cases. But where there is benefit in the situation of traumatic brain injury is actually in prevention of ventilator-acquired pneumonia after a traumatic brain injury. So the incidence of pneumonia was significantly reduced in those who received antibiotics post-intubation for TBI compared to those who did not. However, there wasn't a significant difference in mortality overall. Those with penetrating brain injury, it certainly goes without saying, benefit from antibiotic administration. So in the pre-antibiotic era, so the patients with penetrating brain injury, about 58% went on to develop infections, usually from Staph aureus. But this is now estimated to be 1 to 5% with the use of prophylactic antibiotics. So these should certainly be administered as soon as possible, is the recommended time frame, rather than waiting for infection to develop, because it's almost certainly going to. In regards to chest trauma, the evidence for these suggests that those who are going to develop infections are those that have penetrating chest injuries and with the introduction of a chest tube. So finger thoracostomies themselves have low incidence of going on to have infections, but we do know that everyone who gets a finger thoracostomy then has a chest drain when they get to the hospital. And it's the development of empyemas with chest drain insertion. So that is where antibiotics are of benefit, but usually just for a maximum of 24 hours is the preferred treatment course, rather than the duration of the chest tube itself. There's no benefit in administering antibiotics for patients with blunt chest injuries, as there's no reduction in pneumonia or any ongoing infections after blunt injury without a chest drain insertion. In abdominal trauma, this is typically very complicated because it can sort of be broken into blunt or penetrating injuries as well as solid or hollow organ injuries. And you're going to need to take in different antibiotic considerations for each of those injury patterns, as well as the timing and the choice of antibiotics. But prophylactic antibiotic use is not required in patients with blunt abdominal trauma without hollow organ injury, and no other indication for laparotomy. So those who do undergo damage control laparotomies only require pre-op antibiotic administration, rather than anything earlier pre-hospitally or ongoing antibiotic administration. And then, unsurprisingly, open fractures. This is sort of where the real money is in pre-hospital antibiotic administration, and where we're actually making a difference by the looks of things. So around 50% of people with lower limb type 3, so the Gastillo-Anderson classification system looks at your different types of open fractures and the extent of tissue damage. We'll have a look at that specifically in a second. But there is a much higher incidence of infection in open fractures for the lower limbs, I guess, due to firstly, they're the more common type of open fracture, more significant tissue damage, and less blood vascular supply. So they unsurprisingly have a higher incidence of infection, and our antibiotic administration in these instances is not considered prophylactic, but rather treatment, and getting that treatment in as soon as possible. And then the continuation of those antibiotics, usually for 7 to 10 days, but ideally we should be getting those in within the first hour if we're able to. And that's where they've been demonstrated to have a benefit. So just remind you of this Gastillo-Anderson classification for open fractures. So you've grade 1 and 2 are you can see there. I'm not sure if that's coming up well, but a puncture wound less than 1 centimetre being a grade 1, greater than 1 centimetre but less than 10 centimetre for grade 2, and then it's your grade 3 open fractures that are really benefiting from antibiotics. They've said, just something, usually cephalosporin, so cefazolin 2 grams, and then 1 gram 8 hourly thereafter, right through to grade 3C, that these are your open fractures with significant tissue damage and vascular injury as well. Those are the ones that are sort of looking at a 60% infection rate without antibiotics, with a high incidence of infection even with antibiotic treatment as well. So to conclude, we can see from the reviews of the literature that because of the threat of antibiotic resistance and also concerns regarding alterations to the gut microbiome. The use of prophylactic antibiotics has received a lot of attention, and it's clear that liberal prophylactic use is not recommended and individual consideration is crucial. So a quick overview for head trauma: prophylactic antibiotics can reduce ventilator-associated pneumonia and are indicated for penetrating injury. For thoracic trauma, antibiotic use can reduce empyema after chest tube insertion, but are not indicated in blunt chest trauma. In abdominal trauma, prophylactic antibiotics are suggested for 24 hours after a laparotomy and preoperatively if hollow viscous injury has occurred. And in regards to open fractures, an antibiotic to cover gram-positive organisms should certainly be administered as soon as possible after injury, and then gram-negative cover added for the type 3 fractures as well. Alrighty, does anyone have any thoughts or discussion points or questions on those ones? I think that we certainly know that antibiotics help reduce your infections, but whether there's any thoughts about types or situations where you may or may not use them.